Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. Today, robotic surgery. What if a surgeon could operate on a patient from miles away or even across the country? Dr. Binita Ashar, who until recently directed the FDA's Office of Surgical and Infection Control Devices, joined Stephanie Desmon to discuss the future of robotic telesurgery and why it could lead to better outcomes, particularly for rural patients. Let's listen.
Binita Ashar, thanks so much for joining me.
Thank you so much for having me. I'm excited to be here.
Until recently, you were the director of the FDA's Office of Infection Control Devices. Something that you've been watching over the years, I understand, is this whole idea of robotic telesurgery and the technology behind it. So the first thing I need to understand is, how is a robot doing surgery from across the country?
Yeah, so let me break it down a little bit. I think many of us are familiar with robotic surgery. Robotic surgery is become almost standard of care for hysterectomy and for prostatectomy, removing the uterus or removing the prostate. And basically that involves a surgeon sitting at a console and in the operating room where the patient is and maneuvering the robotic arms using hand controls and foot pedals to perform minimally invasive surgery, meaning through small incisions. This allows magnification and precise movement of the robotic arm. So it's an extension of the surgeon, and the operating room staff remains as they would be for standard open operations. What robotic telesurgery is it's one step removed. Now, take the situation where that surgeon is no longer in the room controlling the robot, but rather located miles away, performing a procedure on that patient. And so the robot is never acting alone. It's an extension of the surgeon, and the patient is never alone. They're with a presiding surgeon that's in the room with nurses and an anesthesiologist. But what it does is it brings the expertise to the patient rather than a patient having to travel miles to obtain that expert care.
The reason that this is coming about is because of a lack of surgical experience in some places?
Well, robotic telesurgery is a reality in certain parts of the world. So it is already happening in India and in China. And there's many robotic surgery manufacturers that either have devices in the US or are seeking to obtain market access in the United States. What's missing is policy-related issues around medical legal, like how a surgeon located in one state might be able to legally administer care in another part of the country, and how reimbursement structures, training structures, that conversation needs to happen in order to make robotic telesurgery a capability in the United States to be able to deliver healthcare to parts of the country that have lack of access.
And folks that have lack of access, often rural hospitals, there's a crisis there?
That's exactly right. So since 2010, over 130 hospitals in rural areas have closed. This means that patients have to travel 1 or 2 hours to obtain care. This is a burden on the system and on the patients themselves as they seek to obtain this care. It reduces outcomes. The longer patients wait, the more likely it is that the situation may be getting worse. And it's just an overall burden on the healthcare system.
So if I live in a rural area, to get to even the next hospital is pretty far, let alone a big center where they perform this type of surgery regularly.
That's exactly right. And in some cases, this costs lives. So there has been data demonstrating that with every minute after a firearm injury, delayed care increases mortality a significant percentage, on the order of 20%. And so move that to situations like cancer care or even routine care, it's difficult for patients to be able to get expert care in rural areas. Now, rural surgeons are the backbone of rural care in America. They're able to care for patients, babies and parents and grandparents. The breadth of information and expertise that they have is enormous, but they need support. And robotic telesurgery is one way to provide that support.
And as you said, they still have to go to a facility that has an actual operating room and a certified surgeon.
Yeah, and how could that work? Initially, it may have a significant cost. Many of these rural hospitals, just to buy the capital equipment, it's going to be very costly. But the benefits, thinking a little bit longer term, are significant and substantial. These patients with robotic telesurgery will likely have better outcomes because they're going to be cared by individuals that have performed these procedures routinely. These procedures are minimally invasive, meaning that they're occurring through small incisions, which means that there's faster recovery time and less of a reliance on opioids. And many of these rural areas have been hit hard by the opioid epidemic. And in general, the outcomes for these patients are going to be better. And so that can translate into better value, better care. And as many of these manufacturers for robotic equipment gain entry into the U.S. market, the competition should drive the reduction in the capital equipment costs.
I was going to ask about cost because to me it feels some of these rural hospitals probably don't have even the robots. So that would be a crucial first step in this whole process. Is there a concern that this is sort of dead on arrival because it's so expensive up front?
There's been literature and discussion around how to overcome some of those challenges. There could be leasing agreements that are arranged with some of these hospitals, and the technology is evolving. There's many different types of robotic surgery platforms, some that are more portable, some that are more affordable than the one present in the marketplace for the most part, which is Intuitive Surgical's device.
And so there'll be more competitors, is what you're saying.
Absolutely.
So you're pushing for better policy?
I think that's the first step. To be able to resolve some of the medical legal issues, to be able to clear the airspace so that the technology can kind of move in and we can experience the benefits of that. Right now, I believe that many manufacturers are interested in pursuing robotic telesurgery, but without an understanding that some of these obstacles have been removed, they may be hesitant around investing in this area.
And there's not a lot of infrastructure out there.
Well, the infrastructure is being created. So I'm a board member on the Society for Robotic Surgery, and they've really taken a leadership role bringing together regulators globally, the World Health Organization, experts in cybersecurity and network connectivity, and leading surgeons to figure out how to train surgeons in robotic telesurgery, both the team that is local to the patient as well as the ones that are remote, and how to establish standards around cybersecurity and connectivity to make this feasible, not just in the US, but globally. My interest is in the US. I think that the Office of Science and Technology Policy that works to advise the White House may be able to coordinate federal agencies to start these discussions. And this doesn't require extra funding or extra administrative costs. This is something that is part of leadership. And really, with a reduction in force and with some of the challenges related to the federal government currently, this doesn't require anything except leadership, coordinating agencies like FDA, CMS, NIST, and other entities to figure out the policies around how to make telesurgery a reality for the U.S.
What made you so passionate about this particular type of surgery?
I'm a general surgeon, so I love all things surgery related, and surgical innovation has been my passion for 25 years at the FDA and even now. And so what I'm seeing is gaps across different areas of expertise. And so what I'm really interested in doing is being able to point out some of these gaps where experts might be able to work together to accomplish something that may benefit patient care overall.
And you said that it was being done in remote places in India and China. What kinds of surgeries are we seeing?
We're seeing the full gamut of surgeries. Something as complex as cardiac procedures and routine as hernia operations. So the technology is present. And in those countries, the highest levels of government have made this a priority in order to care for their patients. And I think a similar approach may be performed in the US to be able to just figure out the policies so that it paves the way for manufacturers to be able to first start small. Maybe it could just be supporting rural surgeons in telementoring and in teleproctoring. And then it could move to easier cases, more routine cases, outpatient surgery cases, and then being able to advance to something a little bit more complex.
You touched on this briefly, but I wanted to get back to, you talked about cybersecurity. Talk me through that.
There are cybersecurity experts, so this is a little bit outside of my lane, but you want to make sure the personal information remains secure and that there is no risk of interference into that network. So there has been talk about creating a healthcare specific, I think, band or cybersecurity link to allow security of that telecommunication. Then there's the telecommunication piece, which is different from cybersecurity, and that's assuring that there is no latency. So when a surgeon moves the robot, the duration of time it takes for the end effectors at the location to move should not be perceptible by the surgeon and should not impair the ability to deliver care. And that latency has been overcome. So the technology is present now. That used to be an issue. So back in 2001, there was a Lindbergh operation, which was the first time that telerobotic surgery was performed across continents. So the patient was located in France and the surgeon was located in New York. Recently, there was another use case that was performed under FDA clinical trial, and the surgeon was located in Orlando, and the patient was located in Angola, and that was a robotic prostatectomy. And so the feasibility is there. The technology is there. What needs to happen is the medical legal concerns need to be addressed, and the training needs to be addressed. And so that's why the Society for Robotic Surgery has been working to bring together experts in surgery and in education and in other areas to figure out how we might be able to develop standards to implement this once some of the policy issues have been worked out.
Do you foresee any issues with acceptance of people, being willing to participate in this when their surgeon is many, many miles away?
I think everyone's going to be hesitant. When you think about the concept of robotic surgery, I think that takes some education. And I think it's going to be important for patients to recognize that this is not delivering care. This is actually supplementing the care that they receive, and that the human component is central to all of these discussions. So that, it's all about education. It's going to be education of manufacturers to providers about the benefits and risks of a specific technology. It's going to be education of surgeons and providers communicating with patients the risks and benefits of using the technology and the alternatives that they may have. But in my mind, I think the technology is actually causing greater emphasis on those communication steps and enabling the procedures to be performed more effectively.
Binita Ashar, thank you so much for joining me.
Thank you for having me. I've enjoyed the conversation.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmon. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.